Dry socket. Dr. Rakesh Koshy, Professor, Department of Oral and Maxillofacial Surgery. Introduction. Dry socket was first described by Crawford in 1896. It's a complication after dental extraction and it's a frequent complication. Definition: postoperative pain in and around the dental alveolus which increase in severity at some moment between the first and the third day after a dental extraction, accompanied by partial or total disintegration of intra-alveolar clot causing foul smell. Synonyms for dry socket: painful dry socket, necrotic alveolar socket, alveolgia, delayed extraction, localized osteomyelitis, fibrinolytic osteitis, alveolar osteitis, osteomyelitis post-extraction syndrome, fibrinolytic alveolitis, and locular alveolar osteitis. Etiology: difficult or traumatic extraction. A bigger trauma would produce a delay in the alveolar healing and it could provoke a thrombosis of underlying vessels as well as lesser resistance to infection in the alveolar bone. Use of oral contraceptives, estrogen and other drugs activate the fibrinolytic system in an indirect way, bracketed, increasing the factors factor 2, 7, 8, 10 and plasminogen, contributing to premature destruction of the clot and development of dry socket. Inadequate intraoperative irrigation. Inadequate irrigation of the alveolus can also play a role in the formation of dry socket. Use of an anesthetic solution with vasoconstrictor or an intraligamentous technique of anesthesia in which the anesthetic is deposited very near to alveolus, mainly in the anesthetic in colder than the corporal temperature, increases the incidence of dry socket in these patients. Advanced age of the patient, immunocompromised state, extraction site in the mandible, excessive or exaggerated irrigation of the socket can all contribute the formation of the dry socket. Hormonal changes, changing levels of endogenous estrogen during menstrual cycle would also influence. Tobacco, the mechanism through tobacco which interferes in alveolar healing is the incorporation of pollutants in the wound or suction effect on the clot in formation. Theories of dry socket. First theory, Burns fibrinolytic theory. According to Burns fibrinolytic theory, after the extraction of a socket, an inflammatory process begins that could affect the formation and retention of the clot. Laboratory and clinical studies have shown an increase of fibrinolytic activity in the pathogenesis of dry socket. Fibrin would disintegrate due to the effect of kinase liberated in the inflammation process or due to direct or indirect activation of the plasminogen, which affects the stability of the clot and facilitate the development of dry socket. Second theory, bacterial theory, comes endorsed by the existence of a high count of bacteria around the extraction site. Anaerobic microorganisms are generally found and the alveolar pain is due to the effect of bacterial toxins on the nerve ending in the alveolus. Dry socket is also more frequent in patients with poor oral hygiene or in previously existing pericoronitis or concomitant periodontal illness. Causative organism, Treponema denticola, Actinomyces viscosus, and Streptococcus mutans. Clinical feature: pain typically appears on second or third day after extraction and it usually lasts either with or without treatment about 10 to 15 days. Pain is localized to extraction socket which will be sensitive to even gentle probing. Although separation is not evident, a sharp pain persists that increases with the suction or mastication and lasts several days. Halitosis is invariably present. The condition probably arises as a result of complex interaction between surgical trauma, local bacterial infection, and various systemic factors. It is common for the pain to radiate to the ear and the ipsilateral side of the head. There is usually absence of a normal, healthy post-extraction blood clot in the socket, which may be empty or contain fragment of disintegrating blood clot. Radiological studies do not show important alterations, and in advanced phases, rarefaction area can be detected. Etiopathogenesis. After tooth extraction, an orderly sequence of events cause normal tissue healing. The alveolar socket fills with blood that undergo coagulation and contraction. Angioblastic ingrowth occurs in the clot while epithelium covers the clot. Fibroplasia in the clot then ensues with cellular elimination of fibrin and blood debris. A variable amount of osteoid is then produced by the mesenchymal cells. Woven bone is formed, followed by osteoblastic and osteoclastic activity that ends in mature bone, often with some loss of total bone volume. This sequence of normal healing does not always occur. In some instances, early clot formation in socket is followed by premature clot necrosis or loss, accompanied by pain and a fetor oris. Classic triad of early extractions: socket clot loss bar necrosis. Pain and fetor oris has been termed by dry socket or alveolitis sicca dolorosa. Intense pain in the extraction site may radiate and be accompanied by low-grade fever and ipsilateral lymphadenopathy. Histologically, this syndrome shows an intense focal osteomyelitis with healing in 1 to 4 weeks by sequestration or resorption of the necrotic socket wall and delayed secondary intention. Management: patient should be radiographed to exclude the possibility of retained fragments of tooth or foreign body. Affected socket should be gently irrigated with 0.12% warmed chlorhexidine and all debris dislodged and aspirated. In extreme painful case, local anesthesia may be required, and in this instance, regional nerve block should be employed wherever possible. Intra-alveolar paste consisting of zinc oxide urinol paste, anesthetic and an antibiotic can be placed. They act principally by increasing the concentration locally, diminishing the secondary effects, avoiding the entrance of remains of food to the alveolus, and protecting the exposed bone from local irritation, in addition to the use of eugenol as obtudant. Place a strip of paste-soaked surgical gauze loosely in the socket. Do not exert pressure on the socket when placing the strip. Intra-alveolar paste consisting zinc oxide, eugenol, anesthetic and antibiotic can be placed. They act principally by increasing the drug concentration locally, diminishing their secondary effects, avoiding the entrance of remains of food to alveolus, and protecting the exposed bone from local irritation, in addition to use of eugenol as obtudant. Place a strip of paste-soaked surgical gauze loosely in the socket. Do not exert pressure on the socket when placing the strip. The complication secondary to the placement of dressing in treatment of an established dry socket are ignored, although some complications have been described after placement of these dressings. Despite the logical supposition that the topical steroid use may decrease the intense local inflammation and hence decrease post-extraction clot breakdown. Literature does not support the use of topical steroid anti-inflammatory medications in extraction site. However, the topical application of an emulsion of oxytetracycline and hydrocortisone has been shown to significantly decrease alveolar osteitis after impacted third molar removal. Unfortunately, contribution of the antibiotic cannot be separated from that of steroid in these studies. Earlier investigation into the fibrinolytic nature of alveolar osteitis indicated that use of para-aminobenzoic acid in extraction would significantly decrease the incidence of mandibular third molar dry socket in a dose-dependent fashion. However, antibacterial nature of PHBA may have contributed to this finding. Alveogel is a brown fibrous paste. Active ingredients butaben, iodoform, eugenol and other ingredients. Other ingredients are olive oil, spearmint oil, sodium lauryl sulfate, calcium carbonate, fibers derived from the bracken fern and purified water. Appropriate analgesics as the non-steroidal anti-inflammatory drugs are useful in managing pain. When it is considered that socket dressing are no longer required, the patient can be instructed to home socket irrigation technique using 0.2% of chlorhexidine. Patient should be kept under review until there are pain-free and socket healing is ensured.